Greetings. This is Dr. Jim Drzegescu, your CHC Medical Director. We are pleased to provide and continue to grow our CHC Educational Library, which was created to educate CHC members about initiatives and best practices for improving the consistency in delivery of care following clinical practice guidelines. These topics were selected based on their overall value for improving our patients' health. Clinical integration relies on our collaboration with each other in order to have the greatest impact for our patients that we collectively serve. We hope you find the presentations in this educational library useful. We value your membership and expertise. If you have any suggestions for topics to add to this library, please let us know. I hope you enjoy the following presentation.
Hi there, this is Dr. Yasmin Ozcan. I'm a physical medicine and rehab doctor here at Payless Hospital. I'm talking to you today about acute low back pain evaluation, specifically in the role of imaging. We don't have enough time to cover all the aspects of low back pain evaluation and treatment, but we want to give you some guidelines in terms of what to do in the case of acute low back pain in terms of your imaging choices. So low back pain is common. You all know this because you see it in your practice all the time. More than 3/4 of adults will have back pain at some point in their life, and it makes up at least 2% of the outpatient visits in your office. Most adults will have low back pain at some point in their life. Almost half adults will have low back pain at any point in a given month. 85% of low back pain in primary care is nonspecific, which means that it's a pulled muscle or strain, something that's not specifically linked to a certain etiology. And most of these will improve over time, no matter really what you do. Imaging doesn't really change the outcome in acute low back pain in adults aged 18 to 50 who don't have red flags and other processes going on. The best way to evaluate these folks is with a good history, a good exam, spending some time with them, and obviously reevaluate them 3 to 4 weeks down if they're still having symptoms. There's a lot of risk factors for low back pain. I just go through these briefly for you. I think we all know most of these. Smoking is a big one. In fact, just smoking alone increases your risk for a spine surgery of some point by about 50%. We think it's something to do with the vascular restrictions related to smoking. Obesity, age, really sedentary work or really physically demanding work, either extreme, can contribute to low back pain, and psychologically stressful work can contribute as well. And then there's the secondary gain issues, workman's comp, job dissatisfaction, education level, all can contribute to low back pain. And you can't overlook the fact that there's psychological factors related to pain, whether it's anxiety, depression, some other issue going on in their life, or a somatization disorder. These are all things that we have to think about when we're evaluating these folks. Nonspecific low back pain has a lot of etiologies. I can't go through all this, or you'd have to do my residency training program. But a lot of it is nonspecific muscle sprains and strains, facet joint issues, arthritis related to the posterior aspects, or even a pull or a knocking or a misplacement of one of the posterior elements. Directional stability issues, having a problem with piriformis or pelvic instability or SI joint, much more common in the female population, and then old-fashioned arthritis and bad posture over many years, working at a desk. Now that we're all doing EPIC, we're all sitting a lot more, and that can contribute to low back pain as well. You have to always think in the back of your mind about referred pain from pelvic, abdominal sources, even cardiac sources, even pulmonary sources can contribute to low back pain. Serious etiologies, things we really need to be aware of: spinal cord compression, cauda equina is a big one. I'll go through that a little bit more. Metastatic or primary cancer presenting at the bone level, epidural abscess. This picture is of an osteomyelitis related to a discitis that has spread to the bone. You can see that pretty nicely on imaging, but you have to have that in the back of your mind when you're evaluating these people to decide whether to pursue imaging. Referred pain from other serious entities such as a pyelonephritis, a AAA, a kidney stone, and don't forget the good old zoster, which usually shows up a few days after the evaluation with that rash. Other causes of low back pain include ankylosing spondylitis, which we do see in this population of age 18 to 50. Compression fracture, usually someone older, but don't forget that there are 50-year-olds out there with osteoporosis. Spinal stenosis, radiculopathy, or pinched nerve, and the biomechanics related to abnormal spinal positioning from scoliosis or kyphosis. And of course, the psychological components related to back pain. People can put their stress in their back just like some people get headaches when they're under stress. Acute versus chronic low back pain is distinguished by how long you've had it. Less than 4 weeks is usually the cutoff for acute. Chronic low back pain is something that's been going on for more than 3 months, and in between is the subacute low back pain that may still be there because there's been improper treatment, or may be there because the correct diagnosis hasn't been made. But most acute low back pain will improve over time. We like to encourage people to move around. The days of laying on your back for 5 days with low back pain are long gone. We encourage people to utilize ice, heat, other remedies, stretching, working with a physical therapist, etc. When you have a patient coming in with acute low back pain, they want you to fix it now. They want you to do something now. A good evaluation, spending time listening to them and examining them goes a long way to calm them down and make them realize you're taking them seriously, and you can reassure them if they're not better in a short period of time that you're going to reevaluate them, and of course always review red flag symptoms with them so that they contact you if something like that occurs. So here's all the stuff I ask when I evaluate someone for low back pain. You can see why the average primary care physician who has 9 minutes per patient has a hard time getting all this done. Some of this can be done in a questionnaire given out ahead of time, and some of this just takes time. It does take a while to do a good evaluation of low back pain. Location, duration, severity, how long it's been going on, any prior history of low back pain. Maybe this isn't acute back pain. Maybe it's a more chronic problem that's recurring. Do they have any other secondary symptoms? Are they losing weight? Do they have a history of cancers or any reason to be worried about malignancy? What's making it better? Is it related to position, time of day? What things have they tried already? And then, of course, your red flag evaluations for neurologic symptoms, including radicular weakness, radicular paresthesia, bowel or bladder problems, is pain worse with Valsalva maneuver, so on. Are things stabilizing or getting worse? What other procedures have they had done in the past? What things have they tried in the past? Perhaps they went through therapy and they're just not doing the program. They're not doing the things that they were taught to do. Or maybe they've had a recent serious infection or serious other problem, something that makes you think more, wow, is this a discitis or an osteomyelitis, something like that. And then I always screen for depression and look for secondary gain issues and psychosocial history, because all of that is relevant, and ignoring that will get you someone with chronic low back pain. Suspicion of systemic disease goes up if someone's got a history of cancer and unexplained weight loss, other systemic complaints like unexplained fever, etc. Anyone with a history of IV drug abuse ups your suspicion for a discitis or other infection. If they've had pain for 4 weeks, if they're older, night pain, no improvement with therapy, all of these things are kind of increase your suspicion to take things a little bit more aggressive in terms of your evaluation and your imaging. Physical exam, at a bare minimum, look at their posture, gait, station. We can do all this when we walk in the room. We see them get up and move around, squat and rise, heel and toe walk. These are all things I can still do, and I'm in my mid-50s. The average person should be able to do all these things. You do want to palpate, look for a step off, look for an area of local tenderness. They should not be tender over their spine bones if they've just pulled a muscle. A quick neuroexam includes evaluation of the lumbosacromyotomes. You can do that with a couple of reflexes, quadriceps, heel jerk, and I like to use the hamstring for an L5 reflex. Check the strength in the myotomes and the sensation in the dermatomes and look at a general tone. That can be done pretty quickly in the office. What else signs are the diagnostic criteria for confabulation, and include things like suggestion, pain when in the back when you're tapping the top of the head, inconsistencies, maybe a limp walking forwards but not a limp walking backwards, those kinds of things. And then I always look for range of motion, tone, and straight leg raise. Other studies, usually there's not a lot of lab workup for an acute low back pain. You would get a HLA-B27 if you're thinking ankylosing spondylitis. If you're thinking there's some inflammatory infectious component, you can get a All right, so there's really not a lot of labs to get. X-rays, you want to get, obviously, if there's trauma, and the ER usually handles that, but don't forget about compression fracture. That's the big bugaboo of acute low back pain in someone with osteoporosis, and as you know, you can't tell from looking at someone whether they have osteoporosis. MRI and CT, if you get an MRI or a CT scan on someone with acute low back pain, you're going to find stuff. Even if they're 20 years old, you're probably going to find something that's not related to the symptoms they have right now. So usually those studies are not necessary for uncomplicated acute low back pain, and usually they're not going to be helpful unless you've got some other red flags or other concerns. So routine spinal imaging really isn't recommended for acute low back pain. If you take 18 to 50-year-olds, and this study was actually done mostly with people that were under the age of 30, they took a bunch of them and imaged them after they had acute low back pain, and 25% of them had problems that had nothing to do with the problem they were presenting with. Inappropriate imaging is costly. It triggers a lot of additional studies, surgeries, other treatment, and also there's the radiation exposure. So really use your clinical judgment to decide whether to get imaging, and don't just get an MRI in someone who's had back pain for 2 or 3 days. Response to conservative treatment and duration of symptoms can help you determine whether you need to get imaging studies. If someone has a straightforward, even a radicular process, and it's very straightforward and they're getting better, I don't order imaging studies. In the absence of red flags, imaging for low back pain in folks that are age 18 to 50, really, I wait for people to have pain for longer than 4 weeks and they're not responding to the conservative treatment that we've tried. And a good therapist will call you up and say, hey, Mr. Jones is not getting better, things are not working, what do you want to do? That's when you call that person back into the office, do your exam again, look for other things, and determine whether you're going to get an imaging study. And in the evaluation of acute low back pain, subacute low back pain, even chronic back pain, you're going to get more return from an MRI than an X-ray. X-ray obviously is your treatment of choice when you're thinking about bony changes, fracture, compression, fracture, etc. So imaging in low back pain, MRI is usually the evaluation of choice. You don't usually need contrast. Contrast is useful if they had prior back issues, if you're wondering if there's a scar, what you're looking at is a scar or a disc issue. MRI is more sensitive and specific than X-rays for infection and malignancy. If you're going to get plain films and you're thinking along those lines, you probably need to couple it with labs. And plain films, obviously, for evaluation of trauma and compression fractures. And a plain film is a good initial evaluation for someone if you're suspecting ankylosing spondylitis. The red flags are the big thing. I know we all know this and we go through it, but it's so important that I feel it's something we need to review. Anyone with a history of cancer or systemic complaints like fever, unexplained weight loss, immunosuppression, IV drug use, anything that makes you think that they could have an occult opportunistic infection, any recent serious infection, a sepsis, urosepsis, certainly an endocarditis or a bone or joint infection, or a recent spine surgery with new onset back pain warrants an aggressive evaluation. Prolonged steroids also puts people at risk for discitis or osteomyelitis. Or again, if there's no improvement with conservative care and you really have worked with them and they've worked with you and things are not getting better, that's when you need to start thinking about, is there something else going on? Spinal fracture is something to really be thinking about in anyone who's osteoporotic or elderly or has had some kind of trauma. Remember, our bone mass peaks at about age 30. Anyone that's smoked excessively, has a seizure disorder, is on meds that decreases bone health, including prolonged use of steroids, they're going to be at risk for osteoporosis earlier than the average person. Anyone that has a history of immobility, perhaps they're at a wheelchair level, they're going to get osteoporosis sooner. So that the index of suspicion needs to be in the back of your mind to evaluate them for a compression fracture when they present with acute back pain. Even if it was just something like swinging a golf club, picking up a bag of groceries. If they've got osteoporosis, they can fracture with almost no trauma. Cauda equina, the big one. New urinary retention, new overflow incontinence, new loss of anal tone or fecal incontinence, saddle anesthesia, which is why I put this picture here because it'll stay in your brain. Saddle anesthesia, motor weakness in the lower extremities that's progressing, or maybe it doesn't make sense. It's not just the L5 nerve root. They've got multiple myotomes of weakness. This is should trigger in your brain to look for cauda equina. Causes include bad spinal stenosis, bad or multiple disc herniations, trauma, or tumor, and that warrants immediate spinal imaging. Someone's got acute low back pain less than 4 weeks of duration. They're in that age group that's relatively low risk. They have no history of trauma. You've looked through the red flags. There's nothing. You reassure them. The natural history is that this is self-limiting. Yes, it would benefit them to evaluate whether their hamstrings are tight, their core is weak, etc. They can work out with a good physical therapist and learn what they need to do. Imaging's not going to change that plan of treatment. The first line of treatment remains conservative therapy. Keep moving, try ice, try flexibility work. Medications as needed. I'm not a big fan of medication for low back pain. I don't really hand out many narcotics. I am a big user of physical therapy. We have a great physical therapy department here at Palos Hospital, and they can help you. I put this book up here because Mackenzie wrote a great series of books for evaluation of and treatment of back pain. And those principles still hold true years later. Once someone has worked with a therapist and has learned a program to address their deficits, they can usually handle recurrent low back pain on their own if they're motivated. So in summary, uncomplicated low back pain or even a single nerve root radiculopathy is usually self-limited. It usually responds to conservative therapy, conservative pain management measures, and work with a physical therapist, and you usually don't need imaging studies. If you have red flags or they fit that criteria of age or they have a progression of symptoms, new symptoms, or there's trauma, then MRI of the lumbosacral spine. If there's a low velocity trauma or there's a history of osteoporosis, steroid use, etc., consider getting x-rays. Conservative treatment remains the first line treatment in the absence of red flags, and that includes mobility, modalities at home, exercise, and working with a good physical therapist. MRI is used for persistent or progressive symptoms, or if you're reevaluating them and things just aren't getting better. Obviously, if you've got a suspected cord compression or spinal cord injury, you're going to go to MRI. You add contrast. If it's recurrent low back pain or there's a history of prior surgery, something where you think there'll be scar tissue getting in the way. One of the big things is to reassure patients and spend time on the exam. I always say that a good physical exam works as well as an MRI for acute pain. And this is because you're spending time with the patient, you're reassuring them, but you're also evaluating them for the various etiologies that can contribute to their low back pain. If you spend time and you explain what you're doing, you will diminish the chance of the patient demanding some sort of study. I find that just explaining to the patient what's going on and what I'm doing helps to empower them and make them realize that, yeah, you are in their corner, they know what to look for, things are going to get better, and then they're working with you instead of against you. Remember also that medicine is an art as well as a science. There are no flow sheets that are going to replace our clinical acumen. If you've got a funny feeling about something, get the diagnostic study. If you're worried, get the diagnostic study. I'm not telling you not to get MRIs. I'm just telling you that putting your hands on the patient, evaluating them, and listening to them will save you a lot of studies. Utilize your resources. We've got great physical therapy here at Palos Hospital and at the primary care. These therapists know what they're doing. They're not afraid to call you if they see something that they're worried about, and they really, really do know what they're doing. I try not to refer outside of the hospital for therapy just because I have such a great confidence level in our therapists here. We're downstairs. If you need an EMG, we're there. If you're not sure whether you want an EMG, for your particular patient, if you're not sure it's going to be helpful or you really don't know what you want to order, give us a call. We're down here to help you. We're happy to see your patients with low back pain. We don't need to see somebody that's got a 2-day history of low back pain, but if you want us to, we will. Just give us a call. We're down here and we're willing to help you. Remember that exercise is medicine. This says what fits your busy day better, exercising 1 hour a day or being dead for 24 hours a day. I've never been a jock. I'm not an athlete, but I exercise every single day. And that's something that I maintain and demand of all of my patients. And we as clinicians need to set a good example and keep moving ourselves. Exercise is one of the best preventative and treatment modalities for low back pain prevention and treatment. For more reading, here are some great articles. If you want to look at where these criteria came from, I'll leave this screen up for you. And these are recent articles that look at different diagnostic studies and why or why not you would want to order one of them. Thank you for your attention, and I'm downstairs in the PT department. I'm happy to answer any of your questions at any time.